everybody. Welcome back to another episode of the Core Consults RX podcast. We're coming at you with another accredited episode.
Yes.
And I actually counted last night, and I'm pretty sure I counted correctly. And this, I believe, is the 40th accredited episode that we've
40?
done. 40.
Wow.
Yeah.
We do a couple a month.
Mm-hmm. It was May of 2021, which
wow.
was about a year longer than I thought we'd been doing this.
Oh, this is the 2-year mark.
Yeah.
You mean a year longer than you thought they'd let us do it?
Well, no, I'm just saying, like, when I was thinking retrospectively, we've been doing it for like a year, I guess.
A year. Yeah, okay.
I didn't realize it'd been 2 years.
Yeah. But it's amazing that they let us do it for 2 years.
I can't believe it.
They're probably not listening anymore.
Yeah, so big thanks to our friends over at freece.com. So yes, we have officially, we're going to say approximately, because I could have missed one if I was counting quickly, but around 40 episodes of accredited topics that you can get credit for.
Almost right on 2 years.
Yep.
And a lot of those, they'll stay up there for a couple years.
Yeah,
so I guess they're probably close to coming off.
We're just now, I think some of our earliest ones are going to start falling off here pretty soon.
Gotcha.
So
we can
redo
those topics.
That's how we do it.
Just kidding. Only if there's important updates.
Yeah. Fingers crossed, because we are steadily running out of topics to talk about. No, but thank you so much to our friends at freece.com. So for those of you who are already members of freece.com and have unlimited memberships or the gold or platinum memberships as they call it now, you already have access to all of our accredited episodes as part of your membership. And if you are not already a member, definitely check out their library of lectures and monographs and all kinds of great information and learning opportunities they have on their website. And definitely encourage you to check their full library on their website. So thanks to them. And at some point during the hour, we will be giving you a super secret code that you'll use in the post-activity test that will be on FreeCE's website. And so you'll go to the website, go to Learn, click on Podcast, select this episode, and you'll use the password that we will give you at some point. And you will have a 10-question multiple-choice post-activity exam to do.
Yes.
And after you get that, you'll get your 1 hour of CE credit for pharmacists and nurses. And today, we are going to be discussing osteoporosis.
We are. We came up with the password before the episode. It'd be fun if we did it live sometime. Just decided midway. Instead of doing the word scramble, we'll just come up with it midway through.
Yeah, that's a good idea. Well, I feel like that's going to go poorly.
Because we're going to be talking about
like 5 minutes.
We'll talk about 3 different passwords, and they'll forget which one it actually is.
And then I'll have to go back and listen to them because by the time it gets published, it'll be a week later.
You'll forget which password it is.
Oh, yeah, for sure.
But yeah, we're talking about osteoporosis today in women and men, but adults primarily is what we're going to focus on.
Some relatively new guidelines.
There are some new guidelines. There's definitely some new drugs in the last 3-4-ish years that might be relatively updated for you for those who learned this primarily in pharmacy school. But there's a lot of background information to osteoporosis. In some ways, it's simple. In other ways, there's kind of a number of guidelines that aren't necessarily conflicting, but they just have subtleties and differences in how they want you to screen and that sort of thing. So we'll try to lay that out for you and be as clear as possible. The drugs are reasonably straightforward, but there is a lot of nuance to them as far as maybe which ones would be preferred over others and which ones to use in different situations. But we'll try to talk through the pathophysiology as best we can, and as well as the mechanisms behind those drugs as well.
So osteoporosis, what is it exactly by basic definition? It's a bone disorder that is characterized by low bone density, impaired bone architecture, and compromised bone strength that predisposes a patient to increased fracture risk. Estimated that 10.2 million Americans are estimated to have osteoporosis, and an additional 43.4 million Americans are estimated to have low bone density and are at risk for developing osteoporosis. So it's considered to be, a underdiagnosed, undertreated disease state that's obviously very prevalent.
Right. And so it's the bone loss, and we'll talk through it, but there's also a significant amount of bone remodeling that occurs, and it's hard to kind of grasp unless you see some pictures of it. I encourage you to look it up. But as far as how it's intercalated and intertwined and over time, how that can change, and it makes sense why the bones become more brittle. And why do we care? Because we don't want people to break their bones, obviously, and especially when you're elderly. a broken bone can be significant and very difficult to recover from, especially if you have underlying brittle bones. But it can also have very poor prognosis depending on when it happens or where it happens for life expectancy after that. So there are a number of factors that contribute to whether or not you're going to be more predisposed to having osteoporosis as you age. Genetics plays a role. Diet and lifestyle is significant. Your hormonal status is a big deal, and we'll talk through that. Other comorbidities and other medications, along with the general aging process, leads to bone loss. There's skeletal factors that lead to impaired bone quality, like I mentioned. Or you might have suboptimal peak bone mass. You might not have achieved the peak bone mass that would have been ideal, and which leads to skeletal factors that decrease bone density. There's other non-skeletal factors that can, like an increase in fall risk, that can lead to a fracture. All of this leads to reduced bone strength, and then low trauma or effectively non-trauma fractures, a fracture that occurs not because you fell, or because you were in a car accident, but just going about your daily life, you had a fracture.
Yeah. Could you imagine that if you get into a car accident and regardless of age, you break a bone, they're like, you got to be on a bisphosphonate.
Have you ever broken a bone?
No.
It's it's like a common question. Like if you're watching, not that I watch dating shows.
Okay, let's be honest.
They
you watch a lot.
They do
of
pop up on my TV on occasion. Okay? And like it's like a first date question. Did you ever ask Jen that when y'all were dating?
I don't remember like outright asking her, but I mean, I
actually
do
think it came up. I'm pretty like, as I was watching that, I'm like, I bet you one of us asked each other if we'd ever broken a bone and talked about it.
Yeah, I do know bones that she has broken, but I can't remember when that was.
I know
discussed.
of Anna's bones that were broken prior to meeting me, so obviously I've asked that question.
Yeah, that's what I mean. Me too, because I've never been.
I bet it was during the dating process.
Probably. That was a long time ago.
But you have not, even though you were an MMA fighter?
Yeah, so I've broken my nose and stuff like that, obviously, and like toes and little things, but I've never broken like a larger bone.
I've never had a diagnosed broken bone. I thought I broke my toe one time and strapped to the other one for a few weeks. It was okay. But I have not.
That's good.
Yeah. My wife broke her pinky.
We should knock on wood and make sure that we keep that, trend alive.
As we'well go through, we'll see that peak bone mass is in your third decade of life.
Here we are.
Does that mean your 20s or your 30s?
I believe 30s, right? Decade?
Well, I know, but your first decade would be 0 to 10. Your second decade would be 10 to 20, point. And your third would be 20 to 30.
That's a good point.
It's kind of like the century thing.
Yeah.
I think we're past it.
Crap.
Dang it.
Well, I guess testosterone.
We're on the decline.
Testosterone level does start to, I guess,
Yeah.
in theory anyway, decline, which can lead to some of that. But I don't know.
It applies to females too, as far as that time frame.
Let's go get a DEX scan.
Might as well.
But
why not?
Yeah. So obviously, Cole already has gone through some of the risk factors for developing osteoporosis, but females are going to be more at risk just generally. Their age, like he said, plays a role. And then there's some other things that we kind of keep an eye out for too that could indicate risk of a patient developing osteoporosis. So patients who have family members, and specifically like first degree relatives, in specifically they mentioned the risk is even higher if there was a parental hip fracture in the patient's family history. But an osteoporotic fracture in first degree relatives is a risk. Low body weight or body mass index can be a risk factor. Premature menopause, so basically before the age of 45. Secondary osteoporosis and rheumatoid arthritis is another one. Cigarette smoking, past or present oral glucocorticoid therapy, alcohol intake of 3 or more drinks per day, low physical activity or immobilization, and then obviously low calcium, low vitamin D intake or deficiency can lead to the development of that as well.
Yeah. There's also comorbidities that can play a role. We referenced a couple of them a minute ago, and there's a whole host of them, but I'll try to kind of list what's most important. But endocrine and hormonal changes definitely play a role. Mike mentioned testosterone deficiency, not nearly as significant to being postmenopausal, but can definitely play a role as well. Hyperthyroidism, primary hyperparathyroidism, and we'll kind of talk through that and that mechanism. Nutritional disorders, malabsorptive states, vitamin D deficiency, inflammatory disorders like rheumatoid arthritis, chronic kidney disease, also different cancers, multiple sclerosis, diabetes. There's a host of them.
Yeah.
I think those are probably the main ones, though.
Yeah. And medications is another potential, I guess, risk factor, because there are certain medications that can increase bone loss or fracture risk. So just to kind of go through a few of these, some of our anti-epileptic medications, for example, phenytoin, carbamazepine, phenobarb, divalproex. The thought is that they can all lead to decreased bone mineral density and increased fracture risk because of an increase in vitamin D metabolism that eventually leads to low 25-hydroxy vitamin D concentrations throughout the body. Some antiretrovirals have been known to cause that, including tenofovir disoprosyl fumarate, the old form of tenofovir. Tenofovir alafenamide obviously being a little bit less likely, but that was kind of one of the big reasons why that other prodrug was developed. Aromatase inhibitors and things like calcium-renin inhibitors can also lead to this as well. Furosemide, because of the increased calcium renal elimination. Glucocorticoids, we've talked about that probably to exhaustion on here. Patients who are using medroxyprogesterone depot, that's being administered every 90 days or every 84 days, I should say. That also over time will increase the risk. Proton pump inhibitors, long term especially. There's even some data with SSRIs, things like SGLT2 inhibitors, pioglitazone, like the TZDs, excessive supplementation with thyroid supplements, levothyroxine and whatnot, excessive vitamin A intake. There's so many things that can put a patient at risk, and it's, especially as pharmacists, it's a good thing to go through their med list and see if there's anything that could be working against them, so to speak.
Yeah. So why does osteoporosis happen? Why is the result of aging brittle bones? There are some secondary processes we may touch on as we go, but primarily for a normal person with healthy bones, there's a homeostasis of bone breakdown and then bone rebuilding. And they call this the remodeling process. Your bones are constantly going through a state of breakdown and then being rebuilt. And that's what kind of part of what maintains their strength. So as long as there's homeostasis there, you're fine. But over time, it kind of gets out of balance, and it can get out of balance for various reasons. But effectively, that process is primarily driven by two types of cells: osteoblasts and osteoclasts. Osteoblasts come from a mesenchymal stem cell, is their precursor cell, and osteoclasts come from a hematopoietic stem cell. But the osteoclasts are what break down the bone in the first process. They call that resorption. So as we go through some of the medications, we may refer to them as anti-resorptive agents. So the osteoclasts break down the bone, and kind of after that, sequentially, the osteoblasts come through and reform the bone. They rebuild it, and that continues on. And I was looking at some stats earlier, and I can't remember them now, but a significant portion of your bones every year are completely remodeled, broken down, and then built back up. I don't want to say it because I don't want to be wrong, but it was something like 25%-ish of your bone mass or something like that. Don't take that to the bank, but I swear that's what I read. Is broken down.
I like how you said it. I don't want to say it because I might be wrong, and then proceeded immediately to say it.
As long as I take a 2-second pause, it's
right.
okay.
No, that's good.
So I pause first.
That's a good.
And I give a caveat. But a significant portion of your bones is broken down and then rebuilt, and it's driven by those two cells. Now, there's much more to that process. There's different steps in that pathway that we can interject with medication to.
Here, I'll pull it up on the screen for those of you watching the video version.
Oh yeah, great. Do you want to go through that?
No, you go for it. I just want to pull it up.
Okay. Well, I was just going through the overview. As far as being kind of the nitty-gritty detail, there's a number of inflammatory mediators that can play a role, like NF-kappa B and various other things. But as far as the step pathway, it ends with the rank ligand, which when we talk about Prolia, is going to come into play with blocking that and preventing the continuation of the step of resorption. So it's going to be an anti-resorptive agent. There's other medications like a sclerostin inhibitor that we'll talk about, and sclerostin plays a role in that pathway. Parathyroid hormone plays a role in that pathway. So there's a host of things.
And like we mentioned, estrogen and testosterone obviously play a role as well. Estrogen in general has a very positive effect on bone remodeling. And that affects males and females. And so as far as, estrogen's, kind of mechanism, it suppresses the proliferation as well as the differentiation of osteoclasts, and it increases osteoclast apoptosis. Estrogen also decreases the production of several cytokines. They can be potent stimulators of osteoclasts, so things like interleukin 1, interleukin 6, TNF alpha. Those are all going to potentially or when you inhibit those and decrease the amount of those in systemic circulation, you're going to lead to increased osteoclast apoptosis. Testosterone also plays a role in bone health as well, and it's even been identified now as having a direct effect on bone reabsorption and osteoblast activity. Most of testosterone's bone effects do sort of relate directly to the metabolism of estradiol and the estrogen bone effects that we just talked about. But definitely, estrogen, obviously the reason why females are more likely to develop osteoporosis, because postmenopausal osteoporosis is probably the most common form. And that estrogen deficiency leads to that bone mineral density loss and compromise of that bone architecture over time. And it's in order to get that back, it's not as simple necessarily as just replenishing estrogen, because as we've talked in previous episodes, that can lead to a whole host of risk factors and whatnot.
Yeah. And it used to be a treatment, and it used to be a not uncommon treatment, but they looked into it, and there's really a not great effect on prevention in fractures by doing hormone replacement therapy. Mm-hmm. It's still done, obviously for other reasons related to being menopausal or postmenopausal, but it is not a recommended treatment for osteoporosis.
Yeah. And estrogen deficiency doesn't always have to be a postmenopausal situation. It could be patients who, are suffering from anorexia, and that's the reason why their estrogen levels are deficient. That can also lead to that would be obviously more of a, secondary cause, but it's essentially because of the low estrogen levels that are seen. So it's not always menopausal or postmenopausal rather patients that are suffering from that. And then when it comes to like male osteoporosis, men are obviously going to be at a lower risk of developing osteoporosis because one, from a population standpoint, larger bone size, greater peak bone mass, increase in bone width with aging, fewer falls. I guess you'd have to.
There must be stats around that.
I was going to say I want to see the stats on that one because I feel like guys have to fall more. I feel like we're way more clumsy. But and then shorter life expectancy. There you go. That one I can agree with for sure. But as male patients age, sex hormone binding globulin is going to increase, which is going to result in less free testosterone that's available, and that's going to lead to less testosterone available that can be converted into estrogen. So, and estrogen is going to inhibit bone reabsorption in men, although androgen deficiency increases that rank ligand, like Cole was talking about, and that release can increase bone reabsorption.
So estrogen, testosterone, very important. There's another hormone that's important, parathyroid hormone. And I want to talk a little bit about the interplay between parathyroid hormone, vitamin D, and calcium. You probably have seen a flow chart related to this at some point. I'm sure it was in DePiro's book somewhere. It's when you're going through pharmacology. But effectively, when you have a decrease in serum calcium, the body's going to respond by letting out some parathyroid hormone. Parathyroid hormone is going to increase osteoclast activity. We're just going to break down the bones to try to increase the serum calcium. So it's going to try to take the calcium that's stored in your bones. There's a number of reasons why we might have low calcium. It could be because we have, low dietary intake of calcium, or we have a problem absorbing our dietary intake of calcium. But it's important because when a patient has osteoporosis, we're going to do a workup to rule out a whole host of things. One of those is we're probably going to check their calcium to determine if we need to check their thyroid hormone, because if their calcium is elevated or low, we probably need to check their thyroid hormone to see if that is elevated or low, and or the parathyroid hormone to see if that's elevated or low, to see if that's playing a role in what might be part of the cause, so they might have secondary hyperparathyroidism, a lot of parathyroid hormone floating around, prompting a lot of osteoclast activity and a lot of excess bone breakdown. So what we might see in that instance is high calcium, because there's bone breakdown that shouldn't be happening because we have too much parathyroid hormone floating around. Vitamin D also plays a role here. So vitamin D is going to assist with effectively the intestinal absorption of calcium. So if you have low vitamin D, it's possible that you might be intaking an appropriate amount of calcium, but you're not absorbing it in the intestines appropriately. It's not getting to the blood, which is going to prompt you to have low calcium, and it's going to cause the parathyroid hormone to be elevated. So again, you would see low calcium, high parathyroid hormone, and then bone loss due to that. So this is why, as we go through, we'll talk about the importance of making sure the calcium and vitamin D are at appropriate levels, and if not, kind of checking that out. And then also possible supplementation depending on what's going on.
And I think we've discussed this too, but this is a big discussion to have when you're talking about chronic care, chronic kidney disease, because obviously if your kidneys are not functioning properly, the way that your body activates vitamin D into its active form, calcitriol, is through one hydroxylation reaction in the liver and then the other in the kidney. And so if a patient's kidney function is low, the vitamin D drops. And then like Cole was saying, oftentimes in CKD that's more advanced, you'll see parathyroid hormones levels rise, and you have to kind of balance that all back out again.
And that's another thing that parathyroid hormone does. It doesn't just prompt increased reabsorption and osteoclast activity. It also increases reabsorption of calcium in the kidneys, and I think it also prompts additional vitamin D conversion in the kidneys. So if you have chronic kidney disease, then that piece isn't going to be as effective either.
Yep.
Yeah.
So if you have a patient that we suspect have some bone mineral density losses, and we're worried about them having a fracture. Maybe we haven't confirmed that they in fact have osteoporosis at this point, but we want to see what their 10-year probability of a fracture would be. You are in luck because we have a tool for that called the Fracture Risk Assessment Tool, or the FRAX. And I'll show on my screen here. It's basically looks at age, sex, weight, height, whether or not they've had a previous fracture, if there is a parent's fractured hip on the patient's family history. Are they currently a smoker? Are they using glucocorticoids? And do they have rheumatoid arthritis? They also assess whether the patient has secondary osteoporosis or in alcohol consumption of 3 or more units per day. And that will give us a percentage. And if we have a T-score of the femoral neck bone mineral density, then that obviously can get inputted as well. But that will give us a percentage of their chance of having a fracture, and can help kind of steer us in the direction of treatment, or maybe at least further evaluation.
Yeah, and I believe, I could be wrong, but I believe it delineates it into a percentage risk of, is it vertebral fractures versus non-vertebral fractures? I'm pretty sure. And so, this is used as we go through some of the diagnostic criteria to assist with diagnosis. As we go through, we'll talk about, you might have this T-score plus this FRAX score, or you might have osteopenia plus this FRAX score, and when you're deciding whether you need to treat or not. I compare it to like the ASCVD calculator, which is of course your risk of having a ASCVD event over 10 years. This is very similar. It's like your risk of possibly having a fracture over the next 10 years.
It's very similar.
And obviously it's just a tool and it's not perfect, but they will use this to guide decision making.
Yep. All right. So if you get to the point where you feel like the person needs to be screened, and actually have their bone mineral density levels checked, one of the most common tools that you'll see is the DEXA scan, dual energy X-ray absorptiometry, and it's a part of the evaluation of bone mineral density loss and part of the workup for osteoporosis as far as getting that diagnosis. The DEXA is used to calculate the bone mineral density at the lumbar spine, the hip, and the proximal femur. Bone density data from the DEXA is reported as either T-scores or in Z-scores. So the T-score is the value compared to that of control subjects who are at their peak bone mineral density. The Z-score is going to reflect the value compared to that of patients matched for age, sex, and so you can kind of use both of those to sort of put the patient in a range of whether or not they're osteoporosis, osteopenia being not quite the threshold of osteoporosis, but definitely having bone mineral density loss. And so the DEXA scan is definitely a good and kind of that's gold standard tool as far as evaluating patients for bone mineral density loss. Yeah. There are other imaging options as well, but we won't go into all that.
And like we said, some of the guidance for screening, treatment choice, not so much diagnosis, can differ slightly amongst guidelines. One guideline, which I believe is this one's World Health Organization, recommends screening patients, women over 65 years and men over 70 years, regardless of any other clinical risk factor, making sure that they have a DEXA scan. Also, postmenopausal women and men above age 50 to 69, younger postmenopausal women and women in menopausal transition can be screened at this age group depending on their risk factor profile. And then postmenopausal women and men 50 and older who've had an adult age fracture to diagnose and determine the degree of osteoporosis. So if they've had a fracture and they're 50 and older, DEXA scan. And then other patients who might be at high risk because of other conditions like rheumatoid arthritis or because they're taking medications like glucocorticoids. Glucocorticoids will be a refrain throughout because they're so high risk. For instance, this guideline considers high risk being a daily dose of 5 milligrams or more of prednisone, or the equivalent for 3 months or more is associated with bone mass or bone loss. And you mentioned osteopenia. So if you're looking, this is World Health Organization, which I think is pretty universally accepted as far as these T-score ranges. I mean, somebody might disagree, but this is what I've seen every time I see these ranges. It's always the World Health Organization who's put this out. You talked about what a T-score and a Z-score is. Mm-hmm. Yeah. So a T-score of -1 to -2.5 standard deviations would be osteopenia. T-score less than 2.5 standard deviations would be osteoporosis. T-score less than 2.5 with a fragility fracture would be severe osteoporosis. I also saw it referenced a T-score less than 3 would be considered severe osteoporosis. It's also important to note that it doesn't just come as like a blanket T-score. It comes as a T-score at certain sites. Mm-hmm. Like I can't remember all of them, but like the femoral neck or the vertebrae or something like that. So it'll give you various T-scores at different sites, and you can assess risk based on the site. You still give them a general diagnosis of osteoporosis, but even as we go through some of the medications, you'll see that some of them have better data in certain types of fractures. So we might choose one over another because they're at high risk for this type of fracture. Strangely, osteoporosis, not something I would have thought of, but it is considered a silent disease because you don't have symptoms of osteoporosis until you've had a fracture. But I think what was surprising to me is that like 2/3 of vertebral fractures go unnoticed. Like they don't have significant pain. Like you literally, that's breaking your back, right? If you break a vertebra, you're broken your back. And so they can have pain, but generally they don't have like a lot of pain, but they might complain that their stature is shorter or they're kind of hunched over a little bit or something where their spine has obviously changed. But I figured if you break a vertebra, like you're going to the hospital. But it's a fracture. Even a fracture of the hip is not necessarily immediately noticeable. There's some physical exam findings you can do to figure out if that might be what it is before you do imaging. But yeah, vertebral fractures are extremely common. I think like the most common. And then hip fractures are very common as well.
Yeah, and in fact, the National Osteoporosis Foundation guidelines, they say for postmenopausal women or in a man that's over the age of 50 who have an elevated risk of fracture, and that they have various kind of bullet points that they would have listed as far as what they would consider at risk for a fracture. The first one obviously being the T-score of negative 2.5 or less, like Cole was talking about, and they mentioned specifically at the spine or hip, and then they say hip fracture with or without bone mineral density testing. So even just the hip fracture alone, it's
clinical diagnosis.
Yeah. Vertebral, that can be proximal humerus, pelvis, or in some cases distal forearm fracture in the setting of low bone mass, so osteopenia, or a FRAX score with 10-year risk of hip fracture that's 3 or greater percent, or for major osteoporotic fractures of 20% or more in a patient with osteopenia.
So that's just FRAX score. They could diagnose it just based on that. And
they did do a little bit of updating with the 2020 endocrinology guidelines, and they do say that a T-score of less than 2.5 or below in the lumbar spine, femoral neck, total proximal femur or 1/3 radius, low trauma spine or hip fracture, regardless of bone mineral density, which is kind of the same, and then T-score between -1 and -2.5, and a fragility fracture of proximal humerus, pelvis, or distal forearm would also count. And then a score of -1 to -2.5, and a high fracture probability based on country-specific thresholds.
And that's the American Association of Clinical Endocrinologists.
Yeah.
So we've cited the World Health Organization, the National Osteoporosis Foundation, and the American Association of Clinical Endocrinologists. All are effectively saying the same thing, but they're just like slightly different.
Yeah.
And like the World Health Organization doesn't even include the FRAX score, from what I can tell.
Yeah. So this seems like a really good opportunity to give you guys the super secret password.
Wonderful.
Which is, of course, BONES. BONES, all capital letters. There you go. Do not tell your friends.
Not the TV show.
Not the TV show.
Yeah.
What the heck isn't that like a Snoop Dogg movie or something too? I'm pretty sure.
I don't know. I remember it as like a whodunit crime TV show. I never really watched it, but it was always on like TNT. Just always.
Yeah. TNT, they know drama. I think that's their motto, right?
that is actually, or maybe it was FX, but it's always on something.
Yeah, always. So yeah, where do you want to go from here?
Do you have any other background stuff before we get into the drugs? I thought, we should probably talk before we get into some of the medications, which we might have come across this naturally, but some kind of lifestyle things that can be changed. We talked about risk factors, and some of that is obviously modifiable, but we didn't really talk about exercise, which is definitely important in the prevention of osteoporosis. It's also important to mention that once you have a diagnosis of osteoporosis, we don't have any drugs that have been shown to reverse that, to get you back to where you were like pre-osteoporotic. But we definitely have data that we can prevent the diagnosis of osteoporosis, or at least delay it significantly. We'll talk about the meds, but exercise is important. Weight-bearing exercise, muscle strengthening exercise is particularly important in this case. A little slightly different than how we're always talking about, some cardio mixed with resistance exercise with strengthening the muscles around the bones. Weight-bearing exercise and muscle strengthening is important. Can improve agility, strength, posture, balance, and then reduce the risk of falls. So that would be a traumatic fracture, which we want to reduce the risk of. Ensuring appropriate calcium and vitamin D intake is important. Smoking is a big risk factor, so smoking cessation is important. We talked a little bit about alcohol, but limiting alcohol consumption, especially for a patient who has osteopenia and are drinking more than the recommended amount of alcohol. Recommending that is important. And then as you age, fall risk factors. So there's a number of those around the house, right? Might be in the bathtub, so installing a handle or a seat. You might have a couple of stairs when you're walking out your front door, maybe putting in a rail or putting a handle on the door frame or something like that you can grab. Cane, walker, whatever it is, because a fall is going to be obviously high risk for a fracture.
You can put wrestling mats throughout your entire house, just in case.
Just looks like an insane asylum.
It doesn't look as good as hardwood floors, but it does the trick.
That's what we need to make, is wrestling mats that have like a laminate look.
Yeah,
just looks like laminate.
I think they have something like that. I've seen something that looks like wood before, but it's actual mats.
Like foam or mats.
Yeah. Like I think they use like those puzzle piece mats these have.
Right.
Yeah.
Yeah,
But
I don't think that would sell very well.
it doesn't seem very cost effective. But I guess if you need new floors. So yeah, as far as we'll get into some of the treatment and management of osteoporosis, and luckily there's been some fairly new guidelines that were published by the American College of Physicians, and we'll talk about some of the recommendations, and we'll also talk about some of the, I guess, discrepancies maybe that some people have posed since they've been published. But they came out in, I believe, January of this year, 2023. And one of the first, recommendations they make for treatment is that they recommend clinicians use bisphosphonates for initial pharmacological treatment to reduce the risk of fractures in postmenopausal females diagnosed with primary osteoporosis. And they give that a strong recommendation with a high certainty of evidence. The other recommendation that they make, and we'll go obviously spend some time going through these, but the other recommendation they say is that the clinicians should use rank ligand inhibitors, specifically the denosumab or Prolia, as a second-line pharmacological treatment to reduce the risk of fractures in postmenopausal females diagnosed with primary osteoporosis who have contraindications to or experience adverse effects with bisphosphonates. They gave that a conditional recommendation and moderate certainty evidence. And then they also say that you could use sclerostin inhibitors, and specifically the ones available is the romosozumab. Did I say that right?
You nailed it.
Romosozumab.
Yep.
There you go, idiot. And that is with moderate certainty evidence. Or you could use a recombinant parathyroid hormone like tirzepatide, or and then followed by a bisphosphonate to reduce the risk of fractures only in females with primary osteoporosis with very high risk of fractures. And they give that a conditional recommendation. So let's start with bisphosphonates.
Sure. You want to start with alendronate first?
Yeah. So
go ahead.
Go ahead. No.
I was just going to say that I never really, I thought all bisphosphonates were equal except for frequency of dosing or route of administration. But there is some differing data between them as far as what type of fractures they work for. So just in general, alendronate, risedronate, the oral ones, and then zoledronic acid, some experts would say that those are kind of the first ones that you would want to consider because of their data. There's also ibandronate, but it does not have as strong a data related to, I believe it is non-vertebral fractures. So specifically, it's effective for vertebral fractures, not so much for non-vertebral. So alendronate is branded as Fosamax. This is dosed as 70 milligrams once a week. For all of the oral options, surely you've heard this before, but they have kind of a weird dosing recommendation, and that is to be sitting upright and take with a large glass of water at least 30 minutes before eating in the morning. It's important primarily for two things. One, for absorption. So the oral bioavailability, or I should say the oral absorption of these is very bad. Even if you take it with black coffee or orange juice, it's shown to be bad. So you can't take it with any food, just the glass of water. The glass of water is primarily to make sure it doesn't get stuck in the throat. And then you want to sit up because it has a risk for like esophageal erosion. So if you have long-term history of GERD and developed Barrett's esophagus or something like that, this really wouldn't be a good option for you because of the concern there. So the potential damage to the esophagus and then the oral absorption is why it has that strange recommendation. But there are trials that indicate that it reduces the rate of fracture at the spine, the hip, the wrist by about 50% in patients with osteoporosis, which I think is pretty good. Yeah, I didn't realize this, but there's a combination product of alendronate plus vitamin D3, and it's branded as Fosamax plus D. And I don't know that I've
convenient name. It really sums it up.
I don't know that I've ever seen that before, but it's there. Yeah. So there talks a little bit about a study with 38,000 patients using proton pump inhibitors in conjunction with Fosamax that have a dose-dependent loss of protection against hip fracture. So there's also a concern for like an interaction with proton pump inhibitors too. But yeah.
And then that's typically once a week is what the alendronate is dosed at, like Cole said. But the risindronate is another one, the Actonel. And then there's also a delayed release form under the brand name Atilvia, which is a once monthly version. But typically the Actonel is once a week. As well. Same kind of administration that you have to worry about with the alendronate. So taking it on an empty stomach, 6 to 8 ounces of water, and then staying upright for at least 30 minutes. And then we have our once monthly option, Boniva or Abandronate, that has the same administration instructions, but you have to stay up for 60 minutes with that one because it's longer acting, obviously.
Yeah. In all of these, bisphosphonates are anti-resorptive agents. They act subtly differently, like alendronate inhibits osteoclast activity and bone resorption. It binds to calcium salts and blocks the transformation of calcium phosphate into hydroxyapatite and inhibits the formation, aggregation, and dissolution of hydroxyapatite crystals in the bone. Whereas risedronate is anti-resorptive, but it doesn't affect bone mineralization in the same way. So they're subtly different ways that they do the same thing, but they're anti-resorptive. And then we're going to talk about some anabolic options that are going to help build bone as opposed to preventing bone from breaking down, which, as you can imagine, when I talked about the homeostasis before, you can see some improvement in bone mass by preventing resorption, because if we're having excessive resorption, but then we prevent it to go back to homeostasis or even have an excess in bone building, then you can still see some bone mass. But the purpose of the anabolic agents is to build bone mass. So those are the 3 oral agents. There's also an intravenous agent, zoledronic acid, which is branded as Reclast. It's just a once yearly IV infusion. And if you look at the data, appears to possibly be kind of the most effective, but there's concerns with it that might make it not necessarily just the first one you start with. But many would consider it the most potent bisphosphonate. It increases bone mineral density at the spine by 4.3 to 5.1%, the hip by about 3.5%, and that's compared to placebo. Over 3 years, it reduces the incidence of spine fractures by 70%, hip fractures by 41%, and non-vertebral fractures by 25%. So when you're looking at some of the guidelines, generally they would say if you have an issue with oral administration, or if you have adherence issues, then this could be the option for you. Once yearly infusion, that's all you have to do it for. And you don't have to worry about once weekly or once monthly dosing or the whole non-eating thing. Obviously, it's going to be more expensive. It's also important to note that with the bisphosphonates, there is a 5-year treatment recommendation. Basically, they recommend limiting it to 5 years, and then after that, doing a drug holiday and reassessing the DEXA scans. And I believe there's some guidance as to if you need to restart a bisphosphonate. I'm pretty sure, I think what I saw was if you have a greater than 5% decrease in bone mineral density over 2 consecutive DEXA scans, then they would recommend restarting. But they do have that 5-year limit on the bisphosphonates.
And one of the things the guidelines did mention is that they want that to be patient specific as far as when and if to take a drug holiday and all that.
True, yes.
Kind of
They're definitely, if a patient is at high risk, or especially if they had a fracture despite a bisphosphonate, then you would want to treat longer. But you might have even switched meds if they had a fracture wall on a bisphosphonate. But we'll talk about that.
And the reason why you needed the drug holiday, because we haven't really talked about why the need for that, right? I don't think.
No.
Oh, okay. So making sure I wasn't zoning out while you were going through something. But there are some concerns as long term, and one of them would be the risk for osteonecrosis of the jaw being one, atypical femoral shaft fracture is another, and severe musculoskeletal pain. There's even been case reports of GI perforation and bleeding even in patients that are taking in patients that are taking bisphosphonates long term. And so just kind of keeping the common side effects being dyspepsia, maybe some like transient musculoskeletal pain. In some cases, it could be more chronic, but it's usually like a tolerable amount, and then some nausea and whatnot. But those rare effects, especially like the jaw necrosis and whatnot, is definitely something that we need to kind of have on our radar and be aware that it can happen.
Yeah, I think it's good to, even though it's rare, to have patients just let their dentist know that they're taking it. If they're going to have any dental work done, or just as they're doing their routine cleanings, they could kind of keep an eye out and ask them if they're having any jaw pain or anything like that, just to get ahead of it if there is that concern. I meant to mention that with the IV reclassed, there's a concern for renal issues, acute renal injury. It also has this kind of, I guess, infusion-related reaction or response that you can have. And sometimes a few days afterwards, you can develop like cold and flu type symptoms that last for a couple of weeks. But yeah, those are some concerns with it.
And it's contraindicated if the creatinine clearance is less than 35 mils per minute.
35.
So, yeah.
35.
All right, so that's some overviews of bisphosphonates, and we'll talk about, we'll go back to those in just a second, but you want to talk about the rank ligand inhibitor?
Sure.
Denosumab.
So there's denosumab, which is branded as Prolia. We talked about where rank ligand kind of plays a role in that cascade. So this is a once every 6 month injection. I believe it's 60 milligrams, once every 6 months. It has to be administered by a healthcare professional. So even though it is just a regular syringe, sub-Q syringe that a patient could definitely do themselves, it's part of the FDA labeling that it's done by a healthcare office. So usually it could be provided by the healthcare office in a buy and bill situation where they just go in and have it done. It can be mailed from a pharmacy to the office for them to hold and the patient to go in and do. It can be picked up from a regular pharmacy by the patient and then brought in to the office to do. It can also be done at an infusion center where they order the med in a buy and bill situation and administer. So it all depends on what the clinic wants and what their staffing is like and kind of their process. But there's a whole host of options, and it's refrigerated, but it's stable at room temperature for 14 days. So if a patient needed to take it out of the fridge to take it with them to their appointment, then they can do that. But it also, so this is anti-resorptive. It also has the concern for osteonecrosis of the jaw. So you would want to give similar warnings about that. And I believe it also has a 5-year kind of general limit for treatment. But depending on risk factors, patient specific, you can go longer than that. Yeah, I'll stop there because we'll touch on it with the anabolic ones. But.
Yeah, well, and it does carry a REMS program associated with it that because it needs to be monitored. The patients need to be monitored for development of any kind of infection. It does have a risk for increase the risk of developing a serious reaction, as well as dermatological adverse reactions and suppression of bone turnover. It's also contraindicated in pregnancy, so keeping that in mind.
Yep.
So the new guidelines sort of have Prolia as like their recommended second line option, whether a patient can't tolerate or didn't find efficacy with bisphosphonates. And so we start with bisphosphonates, then they would say the second line option, Prolia. When the new guidelines were published, there was an editorial that was also published, and the author is Dr. Susan Ott, and she titled it "The Decision to Start a Bisphosphonate is Actually Not That Easy." And so if you go on Medscape, there's a really good kind of summary of that, and she also discusses the systematic review that was published around the same time frame that looked at sort of like the various medications and compared their treatment efficacy. But with that change in or not change, but with their guidelines saying that they recommend Prolia as a second line option, I will say she kind of wrote in her editorial that the whole idea of just everyone's getting a bisphosphonate isn't always that specific, and it depends on the severity and whatnot. And she also mentioned that for example, patients with serious osteoporosis, treatment should basically start with an anabolic medication, which we'll talk about in a second, because previous treatment with either a bisphosphonate or denosumab could prevent the anabolic response of the newer medications. So that would be a problem, obviously.
Yeah.
And then also, she made a point to bring up, the use of Prolia, and said that using that as a second line option isn't always the go-to thing for a lot of clinicians either. And she's basically said that an immediate update is necessary to address the severity of bone loss and the high risk of vertebral fractures after discontinuation of denosumab. And so they didn't really kind of expand on that. And then, she said, this is a quote, she said, "I do not agree with using denosumab for osteoporosis as a second-line treatment. I would use it only in patients who have cancer or usually high bone resorption. You have to get a dose strictly every 6 months, and if you need to stop, it is recommended to treat with a bisphosphonate. Denosumab is a poor choice for someone who does not want to take a bisphosphonate. Many patients and even too many doctors do not realize how serious it can be to skip a dose."
Yeah, I'm actually meant to mention that. So I mentioned the 5-year drug holiday. That actually doesn't apply for Prolia because there is a big increased risk for fractures after stopping it or missing a dose. So generally, if you look at the labeling, it says anything outside of a month is kind of high risk. So you want to try to get it within that month, but you have to schedule an appointment with a provider or with a nursing staff, blah, blah, blah. So sometimes that can be difficult. And then if you're on it for a while, but then you want to come off of it, your risk is going to be increased for a fracture too. So it's either a lifelong thing, or when you come off, you need to take a bisphosphonate afterwards, or we're kind of just going back. Your risk is significant. So it's kind of like, why did we even take that for 3 years or whatever it was? So yeah, that should be considered before starting it. I think that's a good point.
Yeah. You want to jump into the anabolics?
Yeah, and before that, I'll just mention briefly that there is a selective estrogen receptor modulator that's an option to raloxifene, branded as Avista. We won't expand too much on that, but it's used in cancer and can also be effective for osteoporosis, but carries a box warning for increased VTE risk and death from stroke. So the anabolic agents, we have two.
Real quick too, I will say that they did mention that even though the newest guidelines did not directly address those, that they're planning on an update that includes the estrogen and the SERMs and whatnot as part of it in the next couple of years.
Gotcha.
So stay tuned.
So the two anabolic agents we have are teriparatide, branded as Forteo. There's also another generic brand called Boncity. It's effectively the same thing. And then
I guess, is it a biosimilar?
I don't think
it's not technically
biosimilar, but they aren't interchangeable from like a pharmacist standpoint. It has a slightly different volume in the pen, but it's still teriparatide.
Okay.
And then there's abaloparatide, which is Tymlos. So these are recombinant human parathyroid hormone. So it's effectively giving synthetic parathyroid hormone to act as an anabolic agent for treating osteoporosis. And the idea is for it to build up bone. Before treatment, you do want to get serum levels of calcium and parathyroid and vitamin D because you want to make sure that there's not a secondary issue going on because you would need to manage that before you started one of these medications. The Forteo, I believe, is 20 micrograms once daily sub-Q. So these are a once daily injection, which is kind of inconvenient compared to the other options we've been talking about, once weekly, once monthly, every 6 months, every year. So this is daily, which isn't ideal, but treatment is only recommended for 2 years. And that's because of a risk of osteosarcoma outside of 2 years. And I think they had a box warning at one point. I didn't verify this today, but I had heard that got removed. But regardless, there's a concern for osteosarcoma after 2 years. So generally, like Mike mentioned, you would use the anabolic agent for a couple of years, and then you would start an anti-resorptive agent after that. Where I see this used a lot is a patient who had a fracture despite being on a bisphosphonate or has already just had a non-impact fragility fracture. And so they would start with that. They would just be considered very high risk. So they would start with an anabolic agent, then go to the bisphosphonate afterwards. But there may be situations where you could start with this in a patient who hasn't necessarily had a fracture yet. A couple notable things. The Forteo is refrigerated, which kind of inconvenient for patients sometimes, whereas the Tymlos is only refrigerated before your first dose. But the Tymlos is 80 micrograms once daily. It's still a daily sub-Q injection. Dizziness is a very common side effect of these medications, especially in the first 4 hours of dosing. So a lot of times patients will be instructed to take it at night. But you can imagine why dizziness would be a problem for a patient who has maybe already had a fragility fracture, who probably has a walker and is elderly. So I think that's a big counseling point. There's also some like nausea that can be associated with them, but those are kind of the main side effects to be aware of.
Yeah. And the author of the editorial does, and I'm quoting again, but she said if the fracture risk is high, then she typically starts with an anabolic medication for 1 to 2 years. If the risk is medium, then she uses a bisphosphonate for up to 5 years and then stops and monitors for signs of the medication wearing off. But thinking of these possibly, which is not what the guideline necessarily reflects, I think it's one of her bones to pick with the guidelines, is they don't necessarily address the fact that if it's a patient with really severe osteoporosis at baseline, it might be better off to start with that.
Yes.
You might not get the same results down the road if you start with bisphosphonate.
Yeah, the up-to-date authors kind of agree with her, maybe not in as strong of terms, but they kind of give, in very high-risk patients, they kind of give all the options. They're like, you can start a bisphosphonate, but we're also comfortable with you starting an anabolic agent. She seems to be pretty pro-anabolic if it's very high risk. And
she does mention for male patients as well.
Yeah.
Because she said in the guidelines, they don't really address that, although Tymlos, it was approved for male patients as well now.
Yes, not super recent.
Fairly recently.
Fairly recently. It wasn't a long time ago.
But yeah, she did say that there's plenty of data supporting their use in men, and she was a little disappointed that they didn't really go into that.
As far as which one to choose between those two, there's not much of a difference. We do have Forteo is a lot older. Obviously, it's already gone generic. Tymlos, I think, was like 2018 or 2019. So we have more, safety data, I suppose, just post-market with Forteo. So you might feel a little more comfortable with that. But effectively, they're like the same.
Yeah.
There's another agent that Mike mentioned before, romosozumab, is branded as Avinity. And it is kind of unique because it increases bone formation and also decreases bone resorption. It's a monoclonal antibody that binds and inhibits sclerostin. Kind of referenced that before. Not super new, but came out in 2019. And it's approved for treatment of osteoporosis, specifically in postmenopausal women who are at high risk for fracture. I don't think it's used that much, primarily because it has a box warning for increased risk for cardiovascular events and stroke and that sort of thing. So anyone who has a history of that would not be able to use this. Anyone who's at high risk for that, you wouldn't want to use this. And anyone who's not, it's still going to increase their risk. So kind of concerning in that sense when you have some other options. It's also only to be used for 1 year. And then you would want to move to another anti-resorptive agent. But I have seen it prescribed a little bit, primarily because its dosing is just once weekly. I need to verify that. It's either once weekly or once monthly.
Yeah, I got it right here.
But it's not once daily, whereas the other anabolic ones are. And so some clinicians will offer that. I personally just, I feel like the risks are just a little bit higher than the other two, in my opinion.
Oh, it's monthly.
Once monthly.
For 1 year.
For 1 year, yeah.
It's administered as a single-use 105 milligrams per 1.17 ml pre-filled syringe.
Yep, one after the other.
And it is recommended to correct any hypocalcemia before administering the medication. I don't know if you'd said that.
I think it also is supposed to be administered by a healthcare provider as well, which is not ideal.
And the other thing is with a lot of these, really all these medications, patients should still, and we mentioned this briefly earlier, but patients should be on adequate calcium and vitamin D supplementation.
Yeah, Prolia specifically mentions in the label they have to be on vitamin D and calcium supplementation.
Yeah. So anything else with the new guidelines or anything else that we need to go over? Because I think we're almost out of time.
I think we hit it. Yeah, I didn't think I was going to have to rush through those last few. I thought we were good, but we did good.
Yeah,
we did good.
If we do say so ourselves. Yeah. I'll post a link to the Medscape article. For those of you who want like a deep dive. There was Medscape article that basically walks through and gives a really good overview of osteoporosis. It's quite long, but they go through the differential diagnosis. They go through the various lab, testing that you can do for like additional, additional workup to get through that differential diagnosis portion, and then go a little bit deeper into the meds and things like that. So I'll post a link to that for any of you who are interested. It's free to get access to. And I think we're about out of time. So I will say, for those of you, again, who are freece.com members, make sure that you go to their website and take the post-activity test and get your 1 hour credit. And for those of you who are not, definitely go check out the website, see what you think. I think I used them personally even before I was partnered with them to do these type of continuing education episodes. So I definitely am a fan for a while now. I've been using them since I graduated. So very convenient platform. So thanks to them for continuing to partner with us for basically 2 years now. It's been a good time. And for those of you who like more like structure, like lecture style, not episodes, but lecture style content instead of us kind of getting off on our tangents and whatnot, which I feel like we did fairly well today.
I think we're pretty on task.
Yeah. We only did it a couple times, but including right there. But we have our Patreon, which is basically like PowerPoint slides and recorded lectures on various disease states. It's a little bit more structured and, boring, if you will. But you can download the lecture video and the PowerPoint slide set, and it's like $3 a month. So patreon.com/coreconsultrx. There's a whole bunch of different lectures on there, thousands of PowerPoint slides. So check that out. We really appreciate the support that you guys give us on there. And if you have any questions for Cole or myself, then we will have emails in the show notes, phone numbers in the show notes, and you can reach us on any of the social media platforms as well. And until next time, you guys have a great one. We'll see you around. Have a good night.